Good morning, everybody. We'll go ahead and get started, and people can feel free to come in, get some breakfast, get something to drink, and we'll hopefully have a nice chat. So I am thrilled to be here today. My name is Neha Pagidipati. I'm a preventive cardiologist at Duke University, and I'm so excited to be with what is truly a panel of superstars. I mean, this is going to be an amazing conversation because each one of these clinicians up here is like the best in their field, and so I'm so excited to talk with them about patients with cardio-kidney-metabolic disease. And so, as we all know, there have been new guidances coming out around cardio-kidney-metabolic disease, and how do clinicians implement this in their everyday practice? That's what we're going to talk about today. So what I'd like to start with, here are our disclosures of the panel. And just to kind of remind ourselves, at the bottom you can see the definition of CKM, or cardio-kidney-metabolic syndrome. Again, it's a relatively new term. It's been around for a while, but the kind of in the kind of the public consciousness, it's a relatively new term that really the AHA has been promoting to help us understand how all of these different comorbidities kind of come together in the patients that we see every day. And so what I'd like to do is introduce our panel. So as I mentioned, I'm Neha Pagidipati, and then we'll start with Janani Rangaswamy.
Thanks, Neha. It's a pleasure to be here. I'm Janani Rangaswamy, a nephrologist by training and chief of nephrology at the Washington, D.C. VA. And it was an honor to be a co-chair of the scientific advisory group that put out the CKM Presidential Advisory.
Great. Jennifer?
Hi, I'm Jennifer Ho. I'm a heart failure cardiologist at Beth Israel Deaconess Medical Center, where I also serve as Director of Research in Cardiology. My specific interest is in obesity-related cardiovascular disease, in particular HFpEF. And I was lucky enough to tag along with the effort that Janani so aptly led.
Wonderful. Tiffany?
Hi, good morning, everyone. I'm Tiffany Powell-Wiley. I'm a cardiologist and epidemiologist. I'm also a Statman investigator and a clinical investigator at the National Heart, Lung, and Blood Institute, where I'm chief of the Social Determinants of Obesity and Cardiovascular Risk Laboratory. And I was also happy to be a part of this scientific advisory group for the CKM advisory.
Wonderful. And Tahir?
Hi, I'm Tahir Motoresi. I'm an endocrinologist by training. We're talking about how many of us have made diversions in our career. I have a private practice in New Jersey where I do cardiometabolic medicine and lipid disorders, and very, very honored to be on this panel with all these luminaries today.
Great. Are you all able to hear us okay? Yes. Okay, awesome. So these are our disclosures. And this is what we talked about, the CK, just to kind of make sure, just for a couple seconds, we'll just make sure we're all on the same page. So the CKM syndrome is a health disorder that's attributable to conditions that are related to obesity, diabetes, chronic kidney disease, cardiovascular disease of all forms. And it includes both those who are at risk for cardiovascular disease and those with existing cardiovascular disease. And so just to kind of make sure that we're all on the same platform, this was what was outlined in the effort that the leaders next to me put forward about CKM syndrome. These are the stages of CKM syndrome. So in stage 0, somebody is healthy, has no risk factors. We're really thinking about primordial prevention in that population. In stage 1, individuals have excess adipose tissue, so they have overweight or obesity. They may have abdominal adiposity, even if their BMI is not elevated, and they may have impaired glucose tolerance. Stage 2 is really about the individual with more overt risk factors: hypertension, hypertriglyceridemia, metabolic syndrome, chronic kidney disease, type 2 diabetes. Any or all of these would put an individual into stage 2. Then stage 3 is really about subclinical disease. So they have subclinical cardiovascular disease like atherosclerosis, or they have subclinical heart failure. And what I will mention is at the bottom, you will see that risk equivalents do include people who are at high CKD risk or at high risk using risk calculators such as the PREVENT score. And then finally, stage 4 is people with overt cardiovascular disease within the CKM syndrome, whether they have atherosclerotic cardiovascular disease, heart failure, atrial fibrillation. So let's get right into it. We'll start with the first case, which is don't forget about the kidneys. So this is a 64-year-old woman who has a long-standing history of both diabetes and hypertension. She feels fine, and because she feels fine, she doesn't really think she needs to be on a whole lot of medicines. She is currently on metformin at a low dose and hydrochlorothiazide, and on her exam, you can see that she's hypertensive with an elevated blood pressure. Her BMI is 25, and other than that, her exam is relatively unremarkable. So what routine labs should be checked? And I'll go ahead and tell you that these were the labs that were checked. Her potassium was okay, but her kidney function is not. Her eGFR was 45 and her UACR was elevated at 350. Her hemoglobin A1C is also elevated at 8.1. Her LDL cholesterol is 95 and her triglycerides are 100. And so the question is, how do we proceed? And before I turn it over to the panel, I just want to remind us about where she falls in this scenario. So where she falls in this scenario would be stage 2, except remember in stage 3, you can include people in stage 3 who are at very high risk for chronic kidney disease. Now, does she fall into that? Well, we can look at the KDIGO heat map. Now, this is something that many cardiologists may not be familiar with, but every nephrologist and primary care doctor is very familiar with the KDIGO heat map. This is how we understand the patient's kidney function, where things are, and what their risk is for progression in the future. And so if we look at her risk, her eGFR was 45. Now, let me see if I can use the, yes, okay, her eGFR was 45, but her UACR was greater than 300. So she is here in the very high risk category, which technically puts her in stage 3. And we have guidance. This is just to refer you to the document that these wonderful clinicians helped to write. We do have guidance on what to do for each of these stages. But what I'll do is go back to the case and ask people to comment. And I'll start with Dr. Rangaswamy. My first question to you is, do cardiologists really need to be screening for kidney disease? In who do we screen for kidney disease, and how do we do it?
Those are such important questions, and of course, the answer is yes. And here are a few reasons. And I don't say that just because I'm a nephrologist by training, but it is so important, even as nephrologists, I think we don't appreciate the competing cardiovascular disease risk that our patients accrue. There's extensive literature on CKD as a powerful risk enhancer for all phenotypes of cardiovascular disease. And importantly, with the current crop of therapies that we have an opportunity to not just modify the trajectory of kidney disease, but also reduce that excess cardiovascular disease risk, including mortality from several of these foundational classes of therapies. Now, in addition to checking eGFR, which I think a lot of you all, mostly as cardiologists, are pretty good about doing in your practice, why is it so important to focus on that albuminuria? If you note in this individual, it is the albuminuria that actually put her in that high risk. If you hadn't checked that, that individual would be stage 2 CKM in your mind in a lower risk category, and the whole point of this framework of CKM, whether it's the staging or using prevent in a more quantitative assessment, is to calculate what their absolute risk is, to juxtapose them with therapies to accrue most net benefit. So when you're looking at that concept of net benefit, the UACR completely changed the game here, right? So if you didn't measure that, you wouldn't know she was stage 3 versus stage 2. Now, Neha, if you go back to that KDIGO map, the map was originally devised, it was derived and validated to show increasing risk for kidney failure when you use GFR and UACR. But you know what else it really predicts well? Just about every adverse cardiovascular outcome, whether it's MACE, whether it's heart failure, whether it's arrhythmias, and all-cause death, hospitalizations, and you keep naming it. You know, it's got the same color-coded graded response. So as cardiologists, that UACR is your marker as much as it's mine.
That's extremely helpful. And so I'll ask the others on the panel, when you see this patient in clinic, and I'll go back to the case itself. Now, everybody else is not a nephrologist, like me, right? I see this patient in clinic and I think, oh, UACR. Well, now I know that greater than 30 seems to be the cutoff that we're thinking about, but the higher it is, the worse their risk. How do we think about what therapies they should be on to modify that risk? And is it my job as a cardiologist to start to initiate those therapies? And I'll maybe throw it to either Jennifer or Tiffany.
I'm happy to get started. I think I want to amplify something that Dr. Rangaswamy said, which is that UACR is an incredibly important marker for cardiovascular risk. In epidemiologic studies, it's been shown that UACR after natriuretic peptides is sort of the single best biomarker to look at future risk of both HFpEF and HFrEF. So I feel like this is an incredibly important lesson that I learned. I was not checking UACR, sorry, and now I actually do it routinely in practice. I think we have somebody who has certainly evidence of high risk of CKD progression, and they also have hypertension. We have a whole host of of medications that we can sort of really initiate at this point beyond just the metformin that this person is on. So I think ARB, ACE, ARNI, I think are all things that we should be thinking about at this stage. And certainly I can turn it over to Dr. Powell.
So this is a great example of us as cardiologists really understanding and thinking about when do we not only think about treatments for patients with CKD, but also thinking about referrals to nephrology. But for this patient, we really want to think about how can we optimize her medications, and for her, this would be a time to really think about a GLP-1 receptor agonist. She, based on data from the FLOW trial, she would likely benefit from the GLP-1 to reduce her risk of progression of to worsening kidney disease.
Absolutely. Taher, any other thoughts?
Yeah, so these are, patients like this come, I think, routinely to cardiologists. And in fact, there's some data suggesting that patients will come to cardiologists in a sicker state sometimes than even when they present to endocrinologists. So it's absolutely the role of everybody to be able to identify and to treat these conditions. If we wait for somebody else to do it, we see what we see in the implementation space, which is very few patients get on therapies. Specifically in someone like this, I can imagine sitting in front of them and you can take a look at the A1C, you take a look at the lipids, they're not lipid lowering, their blood pressure is uncontrolled. There's so much you can tackle. And for somebody that comes in who says, I don't want more medications, I don't necessarily have motivation, there are still steps you can take to minimize the impact on them, but then also address their major risk factors. So you've heard about, ACE ARBs, you've heard about SGLT2s, GLP-1s, and you can identify those opportunities, but easy things with combo therapy here. For example, if the person says, I don't want to take any more medications, you can still use a combo blood pressure medication like an olmesartan hydrochlorothiazide, a combination diabetes medication like a empagliflozin, metformin. You still have 2 pills a day, but you have now dual therapies on board for chronic kidney disease. That, when I look at these labs, the A1C of 8.1 is not going to hurt her tomorrow. The LDL, obviously, is probably above where it should be. But for somebody who comes in may not have motivation, you have to meet the patients where they are. If they're willing to be on a GLP-1 receptor agonist, great. If they're willing to add on other therapies, great. But these people that come in, you can identify where is the fire actively burning in the CKM spectrum. If it's in the kidneys, direct your therapies for that. Don't add a medication that may address, a biochemical abnormality like an A1C, but not address anything else, if that makes sense.
Yeah, these are excellent points. And so what I'll just kind of summarize to say is, this is absolutely in the role of the cardiologist, because if you think about the 4 therapies at least here that have benefit in this patient population, they all benefit the kidneys, but they also benefit the heart. So this patient should be on an ACE or an ARB. We have to think about an SGLT2 inhibitor in this patient. And then increasingly we're learning that if despite those their albuminuria persists, you want to think about finerenone. And then now with the FLOW trial, we know that semaglutide also has benefit in this population. So these are all medications that not only benefit the kidneys, they benefit the heart and prevent adverse cardiovascular outcomes. So it absolutely is within our realm. The hard part is, and I wrote this case this way on purpose, that's 4 new medicines. And so I agree that you have to meet the patients where they are. Not everything is possible in everyone. And when we have opportunities to combine therapies, we absolutely should take them. Wonderful. So what I'd like to do is to move on to the next case. And now time for something different, something we see every day in a cardiologist's office. Why am I short of breath? So this is a 50-year-old gentleman with known cardiovascular disease. He had an NSTEMI with PCI to the LAD 1 year ago. He has obesity, and he has known HFpEF. So we're not trying to diagnose his HFpEF. We know that he has HFpEF with an EF of 50%. And now he presents with worsening dyspnea on exertion over the last 6 months. He's currently on aspirin, he's on a beta blocker, and he's on a high-intensity statin. And on that, his blood pressure is relatively well controlled, his BMI is elevated at 42, and he looks wet. His JVP is elevated, and while his lungs are clear, he does have some edema on his exam. If we look at his labs, his hemoglobin A1C is fine, his eGFR is okay, so his kidneys are all right, his proBNP is elevated, which is consistent with his exam, and his LDL-C is in a good, that's what I forgot to mention, the last patient should be on a statin. Don't forget statins. Don't forget statins. So even though we take care of the kidneys, we still got to use a statin. This patient is on a statin, and so he's doing great from that perspective, but he's short of breath. How do we proceed? And before I turn it over to the panel, I just want to think about where this gentleman falls in the stages of CKM. He's over there in stage 4. He has known atherosclerotic cardiovascular disease and known heart failure. And there is guidance on what to do in this patient population. This is from the guidance on what to do and how to think about the management of patients in stage 4. So you can refer to that document, but I'll go back to this case. And what I'd like to do is to talk specifically, and there's going to be a lot of discussion at this meeting here around heart failure with preserved ejection fraction and how to manage it in an individual who has other comorbidities like obesity. And maybe I'll start with Dr. Ho. Maybe I'll ask you, how do you think about managing a patient with heart failure with preserved ejection fraction beyond diuresis? So let's assume that this gentleman needs some diuresis. How do you think about kind of disease-modifying and trajectory-modifying agents in this patient?
That's a great question. So I think when we step back and look at somebody who has HFpEF, there are really sort of 3 aspects that I like to try to address when I see them in clinic. The first is volume status, as you already alluded to, they're wet, and so our mainstay of therapy here is, of course, diuretics. In some patients, if they're only mildly volume overloaded, sometimes you can actually get away with just initiating an SGLT2 inhibitor rather than a loop diuretic. So sort of thinking about that up front in patients who exhibit signs of volume overload is something I do pay attention to. I think the second thing that we want to address is, of course, pharmacotherapy for HFpEF. And we are so lucky to be living in this really accelerated time where we've had a couple of positive trials finally. And so I would say here the first line in my mind is really thinking about SGLT2 inhibitors, either dapagliflozin or empagliflozin. And then I think the other class of medications to really think about are GLP-1 receptor agonists. We know there have been 2 trials in the last year, STEP-HFpEF in patients with obesity and HFpEF without diabetes, and STEP-HFpEF-DM, the same patient sample except in the presence of diabetes. Both of those trials showed really sort of huge benefits in terms of quality of life, 6-minute walk distance, and weight loss. And then there was actually a pooled analysis that took patients from STEP-HFpEF, STEP-HFpEF-DM, and then other trials that had enrolled patients on semaglutide with HFpEF. And when we pool data, we actually do see about a 30% reduction in combined endpoint of heart failure hospitalization and cardiovascular death. And then I'll say at this meeting and just this morning, Dr. Packer presented results from the SUMMIT trial, which looked at tirzepatide, which is a dual GLP-1 GIP receptor agonist, and showed for the first time in that trial, powered for the primary outcome of worsening heart failure and cardiovascular death, a 38% risk reduction in that primary endpoint with the use of tirzepatide, again in patients with obesity HFpEF. So those are really agents and really thinking about GLP-1s now upfront that I think about. And then second line are really consideration of mineralocorticoid receptor antagonists, as well as angiotensin receptor neprilysin inhibitors. And then I think the last bucket that I think about is, are there any other contributing factors that might lead to worsening heart failure? In this case, we have somebody who has known coronary artery disease with an NSTEMI. Does this person potentially have underlying ischemia that's contributing to worsening HFpEF? And so I would have a low threshold to consider other contributing factors in this case.
Yeah, that is an excellent point. I know we're here to talk about CKM, but in somebody with known atherosclerotic cardiovascular disease and HFpEF who is doing well and is now more short of breath, it doesn't have to be chest pain. You still need to think about ischemia in this patient population. So one question that I have for, let's ask Tahir. When you start an SGLT2 inhibitor for HFpEF or anything else, do you set it and forget it? Or do you have to kind of keep bringing them back, checking labs, things like that?
Yeah, it's a great question. It is one of the easiest medication classes
Yes.
that I've been able to use in my experience. Some people may be aware of some concerns when the class first came out regarding electrolytes and other things monitoring, there's nothing anymore in guidelines. And in fact, we know that some of the changes that may happen regarding EGFRs are compensatory, these are physiologic, they're not indicative of any problems. And so this is really a set it and forget it class of medications. Low-hanging fruit, they oftentimes have the earliest efficacy on the order of weeks in terms of symptomatic improvement for people with HFpEF. And so that's where there's such good utility is you really can set it and forget it. Now there may be individual patients that you might be a little bit more cautious about depending on other medications they're on. You might want to check follow-up labs. But in my experience, in my clinical experience, it's very, very rare for that to happen. For most patients, this is really set it and forget it.
You bring up an excellent point, which is that not only are SGLT2 inhibitors beneficial both for symptoms and for outcomes in this patient population, they are beneficial immediately. I mean, the time frame in which you start to see benefit for SGLT2 inhibitors in HFpEF is on the order of days to weeks. And so the idea of what a lot of people might do is say, well, come back, let's see if the diuresis works, and if you feel better, we're fine. No. They will do much better if you go ahead and start the disease-modifying agents early on. And so we heard about SGLT2 inhibitors. Maybe some folks in the audience are not as comfortable yet with GLP-1 receptor agonists. We're learning that they benefit like everything, including everything cardiovascular, so we're going to have to get more comfortable with it. Can I ask someone, maybe Janani, can I ask you, when you start a GLP-1 receptor agonist, what do you tell patients? What do you tell patients about starting one of these agents?
These are literally the one class of drug, Neha, where a lot of the times the patients actually come to you asking for it. It is literally the only GDMT class where a patient asks, can I be considered for this class? Everywhere else, you're trying to sell the case. This is all the great stuff that SGLT2 inhibitors do. This is what finerenone does. But then it's always the conversation is here's one more pill, here's one more therapy, and it's a bargain. This is one example of where I really try to latch on to the patient motivation itself. Patients are motivated knowing that they anticipate that they will lose weight, they will likely feel better because they lost weight, and almost the organ protective benefits, which we care about so much, are a little more distant to them, but the more proximal benefits are what they actually care about. Having said that, especially in this era of multi-foundational therapies with GDMT, there are some important considerations. If you had this patient, you started them, say, on a loop diuretic, and right away, it's very appropriate for the reasons you said, the KM curves separate within weeks with SGLT2 inhibition. So you really don't want to say, come back in 6 months and I'll do the SGLT2, right? I mean, there's a huge risk to that inertia. But now these two agents cause some level of, some resetting of volume now. You know, they're not necessarily drying the patient out, but there is a reset that happened with a diuretic, with an SG. And now if you throw in the GLP, and that is your patient that's going to have maybe more GI effects, you're now setting them up to become volume depleted and have a problem. So it is usually in the context of multi-therapies that you have to be more careful and more nuanced. Maybe that's a patient you start at a low dose and keep them at a low dose. You know, that's not a rapidly, titratable agent when you're introducing other therapies at the same time. Conversely, some of the quote-unquote side effects of a medication like hyperkalemia may be attenuated by another class like an SGLT2 inhibitor. So with the GLPs, you'll quickly see that they separate into hyper-responders, more modest responders, and some really don't have much change. And I think that also helps guide how much and how quickly you want to go up.
Yeah, absolutely. So, what I tell folks when they're thinking about starting GLP-1 receptor agonists is start low, go slow. The times when you run into problems is when you try to escalate the dose for GLP-1 receptor agonists too quickly. That's what they did in the trials because they were trying to rush, and that's why a lot of patients didn't tolerate, some 30% of patients didn't tolerate the drug. In practice, we don't see that. If you start low and go slow, the vast majority of patients will tolerate it. And you tell them you might have some queasiness, you might have some GI side effects. They will go away if you stick with it. But if you overeat, it will get worse, and so kind of to be careful, smaller meals. And then I only titrate up really every 4 weeks. And it doesn't have to be another visit, because who has time to see the same patient every few weeks, right? It could just be a message that they send over my chart to say, I'm doing fine, can I titrate up to my next dose? And you don't have to teach them how to inject. They know how to do it themselves. They can go online, and patients can go online and learn how to do it themselves. You don't have to take the time. You don't have to sit there. None of us want to do that. I don't do that with PCSK9 inhibitors either. I say, Google it. And they do. And so it's really not that hard. So I think these are all really excellent points. I don't know if anybody else has, Tiffany, go ahead.
So one issue that we need to really consider with the GLP-1 receptor agonists in particular, but also even with SGLT2 inhibitors, is that accessibility is still a big issue for our patients. And so considering we have data already that shows us even in the VA system, there are racial and ethnic differences in who is prescribed GLP-1 receptor agonists in particular, but also that there are issues around cost being a big factor in terms of access for our patients. And so hopefully we'll have more accessibility as production of these medications increases, but also as liraglutide becomes now generic, and also we now have tirzepatide being available as vials instead of with the single-use pens. But I think we need to be cognizant of the fact that we need to better understand how we can, and there need to be policy changes to really provide access to a broad swath of the patient populations who need these medications.
That's an excellent point, because every day in clinic we see these folks, and just because I want to start them on a medication doesn't mean they're going to be able to get access to it. But the thing that I keep thinking, because it's like the bane of our existence, right, not to be able to get evidence-based therapies for our patients, is things will change. It will get better. We still need to learn how to use these medicines, even if it's not okay right now. I tell my patients, I know we couldn't get it for you today, but hopefully we will be able to get it for you in the future. Excellent points. Well, I'd like to move on to our last case called All the Things. And this is a woman who comes with all the things. And I know that if you see patients in clinic, you see these patients just like I see these patients. So this is a 68-year-old woman who presents to you because she has not been able to see a clinician for many years. She has housing instability. She currently lives in a shelter. But she does have a prior history of obesity, prediabetes, hypertension, and hyperlipidemia. And you do see that she had a non-gated chest CT done for something else a while ago that showed moderate coronary calcifications. Her only medication is hydrochlorothiazide, which she takes irregularly. On exam, she is hypertensive. She has an elevated BMI, but the rest of her exam is relatively normal. Her labs indicate that she no longer has prediabetes. She now has overt diabetes. Her eGFR is low at 50, and her UACR is elevated at 100. Her LDL cholesterol is elevated at 140. Her triglycerides are elevated at 250. And you are an excellent cardiologist who checked a FIB4, and so you now see that this person also probably has metabolic-associated liver steatohepatosis. How do we proceed? So what I'd like to do first is to just think about where she falls in the spectrum. She falls in stage 3. She has subclinical coronary artery disease. She has the coronary artery calcifications, and she also has all of the things that are possible in stage 2. And where does she fall on the KDIGO heat map? So her eGFR was 50, and her UACR was 100. So she falls here in the high-risk category around treat. And so what I will do is I will go to, again, to refer you back to what is in the algorithm for how to think about these patients. But this is not just any patient. This is a patient who has a lot going on. So if we go back to her case, she has subclinical cardiovascular disease, she has obesity, she has diabetes, uncontrolled hypertension, uncontrolled dyslipidemia, she has chronic kidney disease, hypertriglyceridemia, and she now probably has MASLD. And you can say, wow, this is pretty contrived because you put all the things in here. We see these patients all the time, right? And I know you do as well. And so how do we proceed? And what I'd like to do, maybe Tiffany, I can come to you. One of the things that there's a significant emphasis on in the CKM Presidential Advisory is thinking about the factors that are influencing our patients' health outside of the clinic office, thinking about social determinants of health, and how can we understand, assess for, screen for social determinants of health. That's a really important aspect of the guidelines, and I'd love, Tiffany, for you to maybe help us think about how do we screen, not just in this patient where it's very obvious that there are social determinants of health impacting her overall health, but in general.
So we want to think about social determinants of health in 3 different buckets in particular. So we know that there are environmental factors, there are factors related to socioeconomic status, but there are also factors related to stress and psychosocial and mental health factors that serve as social determinants. And these are the factors that intersect and serve as context for the health issues that our patients experience. And really, in many ways, these can drive the development of cardiometabolic risk by promoting changes in inflammatory markers, by promoting changes in immune cells that ultimately affect our patients' risk for the development of atherosclerosis and changes in the myocardium. And so one of the reasons why we wanted to emphasize the social determinants as we think about the development of CKM syndrome is because we know that, in particular, neighborhood factors, community context plays a significant role in the development of obesity. For instance, we've shown that even changes in how people perceive the environment in which they live puts them at risk or lowers their risk for the development of obesity. There have been even clinical trials that have changed where people live, moved them to new environments, better environments, and actually lowered their risk of the development of obesity and diabetes. And so with that type of data, we want to make sure that we are taking a holistic approach and really understanding the factors that drive cardiometabolic risk and what these social determinants are. And so there are screening tools that are being used in the healthcare system that can screen for what we call social needs, which relate to social determinants of health. And these are needs related to transportation, to housing, to financial factors, but also to stressors and factors related to safety within a community in which a person lives. And these social needs are things that can be addressed through referral systems to social workers, to community health workers, but also through coordinated care, utilization of coordinated care teams who can connect patients to resources within their community. And so this patient, especially given her housing instability, is a prime candidate for working directly with community health workers or social workers to connect her to resources to help address these social needs.
Yeah, and those are excellent points. And I think, perhaps what many people may think in the office is, if I ask about these things, then I have to do something about it, but I don't know what to do about it. And what kind of advice could we give people to say, what is it that you can look for in your health system or in your community so that you have at least a plan? Because if you don't have a plan, it's hard to ask the question.
So that's a fundamental question. So knowing individuals who are in busy practices, who are working in healthcare systems that are inundated with patients and sick patients, it's important to look to available resources within either the hospital or within the healthcare system that can address issues related to social needs. And so that means identifying if there's social workers in the hospital in which you work or in the healthcare system in which you work to see what resources might be available. And one thing that is now being required more and more with CMS is that hospitals actually do health and needs assessments within their communities to start to identify what are resources for patients. But we still have a long way to go in terms of making sure that not only are we screening for these social needs, but also that we're able to connect patients to these social needs.
One point I just wanted to make there, as a VA physician, it's been eye-opening for me to see how beautifully the VA does this.
Yep.
Regardless of why a patient comes to see any doctor, they get a mental health screen, they get a suicide screen, they get a homelessness screen, and there are programs that get activated whether they came to get a flu shot or whether they came to see me for lupus nephritis.
Yep.
And I think that's the approach we really need to take, where it's not the chief complaint that they came to you with, and the same question for CKM. You were saying, well, is it my job as a cardiologist to initiate the SGLT2? Well, if it's everyone's job to screen for mental health, like in the VA, and they can do it when they're seeing a nephrologist, yes, a cardiologist can assume ownership.
Yep.
So I think there's some parallel
Yeah.
to that model.
Well, and this gets at this idea of fragmented care. What you're getting at is this idea that this is the kind of patient who unfortunately falls through the cracks, right? Both because of the social determinants of health and because of all the various comorbidities that will shuttle her to various clinicians who aren't talking to each other. And so one thing I'd like to understand from you all, for anybody who would like to comment, is how can we think about more coordinated models of care? And that's not easy for everyone in every health system. If you are in a value-based care system, there is financial incentive to provide great preventive care. If you are not in a value-based system and you're more in a volume-based system, it can be harder if it's a fee-for-service system, but it is still possible. And this is actually information that came out of that presidential advisory, again, if you want more information. But I'd love to hear from anyone who'd like to comment on some of these interdisciplinary care models and how we should think about doing it in a value-based system versus a volume-based system. I don't know if John, any of you want to.
I'm happy to start. So the concept that we put through this advisory for value and volume-based, the way we were approaching it is when you think of staging or when you think of the prevent calculator, what you're trying to do is quantify risk. In one, it's qualitative, semi-quantitative. In the other, like in a calculator, it's more precise. But we need that risk stratified approach at the level of a health system as well. Because currently our model is everyone comes in through the door, everyone gets exactly the same level of care, everyone gets the same lack of care or the same approach. But the approach to somebody walking into the door with multimorbidity and stage 3 CKM and homelessness cannot be the same as a person with good insurance who's stage 1, who's motivated to change their lifestyle and is asking for a GLP. Right. They're completely different, but the thing they have in common is they have CKM syndrome.
Yep.
So when you look at value versus volume, the proposal or the big idea was that in a value-based lower tier of care model, a lot of these concepts we want to deliver and early initiation of therapies and screening particularly can be done outside the office of a specialist. Mm-hmm. And they can be done at the level of a family physician, of a primary care clinician, with support using care navigators and coordinators, with input indirectly from specialists, but not that every patient has to see every specialist.
Right.
Now, there are people who are clearly higher risk, and we offer some guidance on, for example, if someone's persistently a brittle diabetic, and there's evidence of worsening end organ damage, or they're high or very high risk kidney disease, for example, they do need to see a specialist, and that gets funneled into the volume-based model. And depending on resource availability, like in a rural facility, more care might need to be value-based because they don't have access to specialists.
Right.
In areas that are specialty dense, perhaps there could be more volume-based, and this is interchangeable and flexible. So I really think that's the way to go because we simply don't have the resources to put everyone into one bucket.
Right.
Yeah, I want to piggyback off that comment. It's absolutely right. You have to kind of evaluate what your system is and what the availability is for these patients to receive care. Is it something that you have external partners or internal partners within departments that can help you out? Or are you the physician or the clinician that needs to, be responsible for that aspect of it as well? So, there's pathways, for example, in cases like this, clinics like mine that might not necessarily have people in our community that could take on this stuff. We've had to learn the ins and outs of, for example, patient assistance programs. How do you get patients medications for free? She's 68. Does she have Medicare? Can you take advantage of things that are different than the traditional approaches of prescribing medications to a pharmacy to still get the patient on appropriate therapies? And that's where, if you have the ability to create interdisciplinary teams, it's phenomenal. And, Dr. Pagharipati has led a lot of the data showing how impactful that can be for, broad spectrum implementations of these therapies. But if you don't, my perspective is you can't still sit back and say, well, I'm just going to prescribe and see what happens. Then you may need to take on some of the responsibilities of figuring out how the patient gets the care, what things that you can set in place and rinse and repeat for the patients who need it. But I certainly feel like that's something that each person has to kind of decide and individualize decision-making for what your situation is. The one option I feel like is not an option is to sit back and say, I'm just going to direct what medication's right, and then the patients can figure it out on their own, because patients like this will slip through the cracks, and there's still so much we can do to be able to get this patient in the right direction. You might not be able to do everything for this patient, but you can still do a lot to advance her care, whether she has access to a fridge at the, there's so many other things that come to play with this specific case, but there's still a lot you can do for this kind of patient, even if you don't live in a resource-rich setting where you have other external partners.
And just putting my public health hat on a little bit, there are resources within communities that have been developed around community-engaged interventions or public health interventions that may be useful in cases such as this. So thinking about just as an anecdote, living in Washington, D.C., and working with community organizations such as an organization called Food and Friends, which allows for providing food resources for individuals in the community, or working with housing providers to and partnering with them to see if there are resources that will allow that will help a patient such as this. But there are ways in which you can identify potentially specific resources within your community that could help this patient.
These are all excellent points. And so I'd like to kind of bring it back to what we can do in the office when we see this patient in our clinic. And so there's a lot of amazing things that we've heard here that we should be thinking about that go from, kind of system level changes about thinking about how you can address this at a systematic level at your health system, but then bringing it back to what you're going to do in that moment with this particular patient who has lots of social determinants of health and lots of comorbidities. The first thing is recognizing that she has all of these other social determinants of health, and so keeping that in mind when you're thinking about her management. And then the other thing, we talk about these ideal systems, and I'm trying to build one, for better or worse. It's not perfect, we're getting there, but trying to build a coordinated system of care. At the very least, the one thing we can all do is communicate with her other clinicians, right? And so anytime that you start, and being proactive, that's two things, because if I sit back and I say, well, I'm not going to deal with starting an SGLT2, or I'm not going to deal with starting, these other even an ACE or ARB, I'm not going to deal with that, I'm going to leave that to her primary care, that's predicated on the primary care knowing that that's what you wanted to do, and her getting back to the primary care clinician. But if instead you were proactive, we were proactive, and we started some of these medications, we started what we thought was right for her, and then we communicated with the rest of her team. That's at least something every single one of us can do right now that unfortunately, it's hard in everyday clinic to do these things, but that's at least a start, and then we have to go further as much as we can to think about the other resources that we can provide. Any last thoughts, parting wisdom from this amazing group of panelists?
Well, I just want to say, the best part of being part of this world-class scientific advisory group was just being able to have front row seats and listen to so much expertise and so much wisdom and experience. But I really hope that this is a conversation. This is not meant to be a one and done. Here's the advisory. Here is a nice framework. This framework only matters if it's actually doing something on the ground, changing practice. And we really welcome feedback from practicing clinicians like you and what barriers you're facing, so that as we now go into the 4-year implementation phase that was announced by American Heart for the CKM project, and start developing care centers of excellence and understanding what the barriers are, I think direct feedback is so helpful. So, we definitely would welcome that.
Wonderful. Well, thank you all so much for joining us, and I hope you have a wonderful scientific sessions. Thank you.